So data analysis, and how does that help my CLL? So there's lots of different sources of data. Jane and Moira touched upon some trials, so randomized control trials ranging from phase 1 up to 3 and sometimes 4. Observational studies. Observational studies include cross-sectional studies where we're just kind of taking a snapshot of time, case control studies and cohort studies where we're either picking patients with a disease and patients without and looking back, or following patients and looking at their journey going forward and following them over time. Registries and databases, biomedical research and surveys and questionnaires. And then randomized control trials. So again, you've heard a little bit about this already. So phase 1 trials, some of you may well be considered at some point for phase 1 trials. We do have a few patients going into phase 1 trials. These tend to be either first in human or just testing out very new treatments, but in the hope that actually they are, effective treatments for CLL. And then phase 2, slightly larger numbers of patients. How effective is this treatment in that certain disease? And then phase 3 is these larger scale trials, really looking at effectiveness, comparing to standard therapy. Are we improving upon our standard treatment? And really looking at, and all 3 phases are looking at side effects. So really relating this back to CLL, a trial that some of you may well have been involved in is the Flair trial, which is still recruiting in one of the arms. So this is a randomized phase 3 trial where we're comparing FCR chemotherapy with ibrutinib-based therapy, so ibrutinib rituximab, ibrutinib, or ibrutinib venetoclax. The area that's been reported fully is that of FCR versus ibrutinib, and showed that ibrutinib rituximab had a better progression-free survival at 4 years. The ongoing recruitment is into the high-risk arm, which is comparing ibrutinib and ibrutinib venetoclax. Now, as a follow-on from this, there's static, which, if you have been on Flair, you may well be invited to transition onto static. So this is looking at having intermittent treatment with ibrutinib versus continuous therapy, and randomly being allocated to that. And the patients so people that have not achieved a good response or kind of a full response on ibrutinib will be not randomized and will continue on ibrutinib on static. So that will enable them to continue on their therapy that's working but hasn't achieved an adequate response to allow for a break. But those that have achieved that response will be randomized. And I guess the main reason for looking at this is that, albeit these new treatments are kind of excellent and have a really improved side effect profile, they still have side effects. Does giving breaks from therapy reduce the risk of resistance developing? So we know that some patients that are on ibrutinib can go on to develop mutations and changes in their disease that makes them resistant to therapy, and does having a break from treatment overcome that? And having a break from therapy, does that improve quality of life? Another area where trials are really important in CLL is just shaping our current treatments. So I think it was mentioned before how this kind of the feeling that trials were actually kind of last-ditch saloon for patients, and when there was nothing else. But actually, these trials are kind of frontline trials looking at, can we improve upon our treatments? So by changing one drug for another, can we do better? And so Elevate-TN was a trial looking at acalabrutinib with or without obinutuzumab versus chlorambucil obinutuzumab. And this was in patients that were untreated, phase 3 trial, randomized, and showed an improved progression-free survival with the acalabrutinib with or without obinutuzumab. And again, that was borne out in longer follow-up. And this has led to the widespread use of acalabrutinib first line. So these trials have been pivotal in getting access to our patients for these new drugs. CLL14 was a phase 3 trial comparing treatment with venetoclax obinutuzumab with chlorambucil obinutuzumab in untreated patients with comorbidities. And you'll see the progression-free survival here was much improved with the venetoclax obinutuzumab combination, and this has again led to us having access to venetoclax obinutuzumab as first-line treatment for our patients. GLOW is one of the randomized trials looking at ibrutinib venetoclax combination, and that was compared with chlorambucil obinutuzumab, and has shown a much improved progression-free survival. And ibrutinib venetoclax is the latest first-line option that we have now to add to our armory of options. Observational studies, so kind of, I guess, have less impact in the sense of direct treatment, but have real value in certain areas. So Oxplored is a trial that some of you may well be involved in or have been invited to be involved in. So this is an observational study. So early stage CLL or monoclonal B lymphocytosis, patients are monitored, they have some baseline blood tests and then monitored and the aim of this trial is to look and see, are there factors that can give us an indication as to who is likely to progress, who is likely to have a more aggressive disease course, and develop CLL that requires treatment. And the kind of offshoot or the next step that is being planned from this is a further trial that is called OxCure, with the aim of looking actually then, if we've identified this group of patients that are likely to require treatment in the near future and behave, have CLL that behaves in a certain way, does early intervention lead to improved outcomes? And so I think that was a question earlier this morning about early intervention in the era of targeted therapies, and that is certainly something that's being looked at here. And actually, in terms of this observational study, direct benefit to a patient at the time of entry is limited. It's not going to affect that your CLL journey directly, but actually the kind of wealth of information that's gathered is really invaluable. It will help us guide the treatment of CLL for the future. EPIC is another observational study that you may be invited to be part of, and that's looking at patients on acalabrutinib, first line, and looking at real-world outcomes, progression-free survival, and just to compare that to the trial data. So what next? So we are now in a position where we have these excellent frontline treatments, but not always entirely clear which is the right choice or if that indeed exists. So there are ongoing discussions about the next frontline UK trial and how that might look. There are still newer BTK inhibitors and also BCL2 inhibitors. So still more drugs coming through that maybe have better outcomes and or better side effect profiles. One of the big questions that we have is what's the best sequence of treatments, so which should we choose first and then to utilise next, this will lead on nicely to Uncover Plus. So Uncover Plus is something that Dr. Umair Khan is going to talk to you about, and he'll also discuss big data, I hope, for you. But looking at how, the data set that we have can hopefully give us some information in these areas. So I'll pass you over.
Right, so I'm Umair Khan. I'm a hematology registrar just across the road, and it gives me immense pleasure to be here in front of all of you in this audience. So thank you very much for inviting me to present this. This project I've been working on alongside my PhD, and it was a bit of a side hobby, but it's become more of a real thing recently upon completion of my PhD. So really excited to tell you more about this project. And it's just a teaser, similar to my introduction about big data. So happy to talk to you a bit later if you have want more information about it. So Dr. Williams talked a lot about trial data, which is very, very important in altering treatment of patients. But what is also important, and is the other side of the coin, is real-world data. When we approve drugs in clinical trial setting and it is then applied to clinical practice, how does that actually work? And what are the outcomes associated with these treatments in real practice? And this is what real-world data pertains to. And this is just a little table that we've created which summarizes the difference between trial data and real-world data, just to help you understand the differences between the two. So with the patient population, as we're looking at the whole patient population, it's an unselected cohort. We're looking at all patients. Whereas with trial data, you have a highly selected group of patients. And so that leads to a limited cohort of patients, whereas in real-world data, you have a larger cohort that you can look at. In terms of the treatment that they received as well, in trials, you have set protocols that you follow, whereas in clinical practice, that can vary depending on the patient's circumstance. And generally, that means that the real-world data is more applicable and has more meaning in terms of generalization to the larger population compared to a trial data. And that's why there's increasing interest in looking at real-world data in this context. So for me to talk about Uncover Plus, I have to just quickly talk about Uncover, which was is the predecessor study. We're still working on it. And that stands for Understanding the Impact of SARS-CoV-2 Infection in Patients with Blood Cancers. And there's two parts to the study, really. The first part is looking at, are there certain patient demographics? And what I mean by that is, their age, sex, where they live, ethnicity, et cetera, does that determine or can that help us understand which patients develop COVID? And then can those factors alongside treatment help us understand who develops severe COVID? The second part of the question is to do with the outcomes. So in terms of, we know that since the pandemic, the treatment algorithms have changed, particularly in CLL with ibrutinib, et cetera, coming into first-line setting. How has that changed outcomes for patients? And what is the side effect profile associated with that in the real world setting? So when we were getting this data for the study, we realized a real opportunity here that, getting this routinely collected data can really help us answer other important clinical questions, which Dr. Williams alluded to earlier on. And that gave rise to Uncover Plus. Uncover Plus is essentially the expansion of part 2 of Uncover, where we aim to create a pipeline of real-world evidence studies which prioritize clinical questions at hand and answer them systematically. And I'll show you what I mean by that in a couple of slides' time. Oh, I think it's not really projecting. The format has changed a little bit. But what this is trying to show is that we have been in discussion with NHS England for the last 4 years. And now I'm pleased to say that we've got a hold of 10 different data sets from NHS England, which pertain to cancer registry, the SACT data, which tells you about the treatment information. There are very important information related to indices of multiple deprivation, so in terms of markers of social deprivation. Also HES, hospital episode statistics, so whenever someone is admitted to hospital, and they have an episode having to be admitted, and if they receive treatment, then these data sets capture that. So you can start to imagine the amount of data that this is capturing. And with this data set, we currently have data on about 180,000 blood cancer patients, so a huge cohort. And of these, 17,000 have CLL. And this number will increase as we're currently applying for an updated version of this data set. So we should have more updated until 2023 data set. So this is the last slide, just describing some of the things that we aim to look at. So I just want to perhaps highlight treatment sequencing first, which Dr. Williams was alluding to. It's not very clear, ibrutinib first, venetoclax first, what do we give first? And so understanding what's the optimal sequencing in patients and what that may look like in different patients will be very crucial here. And so we can start to understand that, although these data are not, this data set is not collected to answer this question, but we can start to get a sense of what treatment sequencing may look like and how is that associated with outcomes. Again, the demographics of the patients, how does that correlate with outcome and survival? Do we have geographic variation in the treatment that patients receive, depending on where they live? Are there certain issues surrounding access to healthcare, which is very important? And what is the actual side effect profile with these drugs? When you actually use it in clinical practice, then what does it actually produce? And what are the side effects that we see in clinical practice? So you can see these are some of the questions that we're starting to develop around it alongside key stakeholders in our study. And I'm sure you'll be hearing more about this in the coming months to years, as this data set has got a lot of national interest now and is part of the NCRI group study. So happy to take any questions on this, but thank you very much for your attention.
There's a lot of research in various areas of for blood cancers at the moment, as we know. And one of the themes that I'm on a group with Blood Cancer UK, and we look from a patient perspective at applications for funding. And one of the things that comes through is that a lot of research is trying to look at exactly what you've said, really. What is the best treatment to give from the very beginning? Because, am I right or wrong, that's terribly important, isn't it? Because to actually try and get that right, I mean, I suppose you can't always get, one shoe fits all. But is that sort of like the intention of establishing this fantastic data to try and get a first frontline? Or not?
I think a great question. So I think that's one of the questions that we do want to understand. What is the best treatment to give in the first line setting, but also not just the first line setting. What's then the best treatment to give in the second and third line setting, and what does that sequencing look like? And what if you started with another drug? Then what's the next best drug to give? So there's different aspects that one could look at in regards to that.
Thanks. Umair and Stella, thank you very much. When do you expect to see, if you haven't already seen it, first deliverables from this? How long is it going to take us to get to a point where we're seeing meaningful statistical data coming out that says, he's this old, he's got this condition?
So it's been a huge undertaking so far, and when we got the data set, just to give you an idea, we had about 20 million rows of data and 400 columns. And you, sort of being from a technical background, perhaps you can appreciate, and other people as well. So it's been a huge undertaking to deal with that type of data set, and we've been working with important stakeholders to try and clean that data and curate it. So we're very close to it now. So I think in a matter of weeks, we should start to be, we're planning to starting to analyze the data. And that's alongside getting more up-to-date data set as well. So we've created a pipeline of cleaning this data set and curating it. So once that's happened, we should be very quick to start analyzing the data. I think in terms of output, it will probably take a few months at least to start to understand what the data looks like and what it means, and the quality of the data as well. And that's another discussion with trial data, because it's collected in a very systematic way. The quality is different compared to real-world data, which is collected for different purposes. It's just routinely collected data. So we want to understand what's the actual quality of data, and all of these things will become more clearer as we start analyzing. But I suspect within the year, we should start producing outcomes.
That's terrific news. So that means I can expect a web talk towards the end of the year.
Absolutely.
You're booked. Well done. Thank you very much.
I have a question myself. In terms of the empirical data that you've just been talking about, Stella, you mentioned the quality of life assessments, which I think is somewhat more subjective. So in terms of actually doing an assessment of quality of life, how do you undertake such an assessment to give you quality and objective data out of that?
So there are various kind of tools, I think, for quality of life assessments. They tend to be questionnaire based, but standardised in that sense. And each trial will have a separate or a particular protocolised questionnaire that they will use and follow.
And just bringing the angle of real-world data, there are things which NHS England does collect on patient-reported outcome measures. It's not the focus of our initial study, but we plan to sort of look at that going forward. There are criticisms about how do you assess quality of life, and there are questionnaires, as Dr. Williams alluded to. I think it's very difficult to really measure what it actually truly means to an individual patient. And I think having the conversation with them, it helps you understand that. But having these standardized questions help you to objectify it in some way and help you understand the impact of the disease and treatment on quality of life.
Thank you. Thank you very much to Dr. Williams and Dr. Khan.